Assalamu alaikum students. This is our third lecture and we will be discussing in detail the normal electrocardiogram. What is an electrocardiogram? So whenever a cardiac impulse passes through the heart, electrical currents also spread from the heart into the adjacent tissues surrounding the heart. So a small portion of this current spreads all the way to all surfaces of the body. Now if we place electrodes on the skin on the opposite side of the heart, electrical potentials generated by this current can be recorded. The recording is known as electrocardiogram. So here in this figure, now we have whenever somebody goes to hospital to do an ECG, you must have observed. Usually we do a 12 lead ECG. Now basically, what are leads? Leads are these connections. For example, this is lead 1. This is lead 2 and this is lead 3. We have 12 lead ECG basically. In this we have bipolar limb leads in which we have two poles, for example a positive and a negative pole. This would be our lead 1. Now the relative positioning of the electrodes which makes a lead. A lead is made if you connect it with two electrodes. That's complete a lead. So the lead 1, this is your right, this side it is your right side. This is your right arm, and this side is your left side. This is your left arm. So if we place the negative terminal on the right arm and the positive on the left arm, so this completes a lead. This is called lead 1. Now there is a rule that whenever, for example, if we obtain different electrical events of the heart from different leads, now we must know, for example, if we make a recording in lead 1, what are we looking at? And if we make a recording in lead 2, what are we looking at? So there is a rule that the eye should be centered on the positive side. So in case of lead 1, if our eye is here on the positive side, so what side are we looking at? We are looking at the left side of the heart. So in lead 1, we would be looking at the left side of the heart. Now coming to lead 2, this is lead 2. Now in lead 2, you can see that the negative electrode, it is connected at the right arm and the positive is connected at the left foot. So it completes a lead, and this is called as lead 2. Now where is our eye should be on the positive side. So the positive side is the left leg. So this is where our eye would be and would be looking at the position of the heart, at the areas excitation of the heart in an ECG. So what are we looking at? We are looking at from the bottom. So this is lead 2. So bottom, inferior. So we will be seeing the inferior surfaces of the heart. Now coming to lead 3, this is your lead 3, this one. And here you can see the positive is connected at the left foot and the negative is connected to your left arm. So where should again we be looking at? We should be looking at the positive side. Our eye should be here, and this also gives us a depiction about the inferior aspects of the heart. So this is lead 1, 2 and 3, and you can see this is a triangle formed around the heart with these leads. This is called as the Ethiopian triangle, and there is an Ethiopian law that if you know the voltages of 2 leads, you can calculate the third one. That is 1 plus 3 is equal to 2. So you can, if you know the 2 voltages, then you can calculate the third one. These are the bipolar leads. Bipolar means you have two poles, a positive and a negative. You have 2 electrodes. Now we have in an ECG, we have 3 bipolar, lead 1, 2 and 3. And then we have augmented unipolar leads which are called as AVF, AVR, AVL, which you will learn in a second. And then we have precordial chest leads that has 6 leads, that is from V1 to V6. So this makes a complete set of 12 lead ECG. Now, one difference here, that is the bipolar leads and the augmented limb leads, that is AVL, AVF, AVR, they look in the coronal plane, or you can see the frontal aspect of the heart. Whereas the chest leads, they look at the transverse positioning, or the horizontal, you can say, aspects of the electrical activity that are occurring in different areas of the heart. Now, these are certain important points regarding to ECG that you must memorize. These are certain rules. Number one, if a positive charge moves towards the positive electrode, an upward deflection would occur. Upward deflection would be like this. For example, this is your isoelectric line. No recording would be occurring over here. This is a flat line. So whenever you have a positive charge that is moving towards a positive electrode, for example, this is the wave of depolarization, which we would do it with a plus sign, and it is moving towards an electrode which is positive. So what deflection would we record on an ECG paper would be positive deflection, a deflection above the line, that is called as upward deflection. But if a positive charge moves away from the positive electrode, then a downward deflection would be occurring. So if a charge is moving this way, away from the, this is your positive electrode, and it is moving towards the negative electrode, away from the positive, so then you would have a negative deflection. A negative deflection would be below the line, below the isoelectric line, below the flat line. If a charge is not moving at all, no deflection, common sense. If there is no charge movement, so there would be no detection whatsoever by the ECG machine. If a charge is exactly perpendicular to leads, there would be no deflection. So for example, this is a positive electrode and this is a negative electrode, and you have, if you have a charge right here perpendicular to this to leads, so then equally spaced between the positive and the negative, so then there would also be no deflection. You will have a straight line. Now for repolarization, we have certain rules that are opposite to that occurs in the depolarization. For example, if a negative charge is moving towards the positive, the electron, then there would be negative deflection. In depolarization, we saw there is a rule that if a charge moves towards positive, we have positive deflection. But for repolarization, if a negative charge is moving towards the positive electrode, we have negative deflection. And if it is moving away from it, vice versa, we'll have a positive deflection. So these are some very important principles which you must. Now these principles, we will reinforce them over here. For example, previously we did in the conducting system and the SA node, we did the conductive system of the heart. Now all of you know how the impulse is generated in the SA node. So once this impulse is generated into the SA node, now this is lead 2. I have given the negative, you can see over here, the negative, and this is the positive. This is your lead 2. Most of the recording we do is from lead 2 because it is also called as a rhythm strip. It is the longest, it covers the longest area you have seen of the heart, and so we can easily depict any abnormality. So usually we look at lead 2. So for example, here we are considering lead 2. This is your right side and this is your left side. So you have a left on left foot, remember there was positive and the negative terminal was at your right arm. So this is at consider this in all of these scenarios. So negative at the top and positive down at the left foot, lead 2. So now SA node gets excited. So what happens? It depolarizes. And what is depolarization? Positive current. So the positive current spreads across SA node, and you can see down here, you can see the ECG recording at each stage. So for example, the SA node, it depolarizes. Now the current you can see is going down. So all of these vectors, all of these currents that are being generated in all of these areas, they sum up, and the sum of when they sum up, the sum vector would point downward. It would point downward. So now what you think is happening over here? The flow of the charges is towards the positive electrode. So when the flow of the charge is towards the positive electrode, what would you see on ECG? On ECG, you are going to see when the atria are fully depolarized, you can see an upward deflection. This is called as the P wave. Here just the excitation has started, so you cannot record anything. Very feeble, you can see it is going up, the line is going up above the isoelectric line, but as you in the second picture you see all of the atria has depolarized, so a big vector is formed because there is summation of the currents from the right and the left atrium. And when this big vector is formed, where it is going to go, here towards the positive electrode like this, and since the flow of the charges is from the negative to the positive, so as a P wave you will see a positive deflection. Now after P wave, the charges now are flowing, all of the atria has depolarized, so now the charges, they would move towards the AV node. Now in the AV node, you know, there is a delay of certain period, so no electrical activity would be detected here. Just look at here from the P wave, and this is the isoelectric line. This is called, since the start of the QRS complex, this is called as a PR interval. PR interval. So when these depolarization waves, they go towards the AV node, there is delay in the AV node. No current is flowing, or it is flowing so feebly that it is not being recorded on the ECG. So you can see the straight line over here. This is called as a PR interval. So we had atrial depolarization, and then the spread of the this depolarization to the AV node with certain delay. And then just before the start of the ventricular depolarization, we have this PR interval. So now the charge, now this depolarization wave would go downwards and would, first of all, you know that there are two bundle branches, the left and the right. The left usually depolarizes the right side. And first of all, before the apices are depolarized, what happens that these currents, and they usually go and first depolarize the septum. This is your septum. So the flow of the direction of the current would be in this way. It would be upward. Now, considering this is your positive side and this is your negative side, so now you can see that the deflection is away from the positive side. It is going towards the negative side. So what would you have on ECG? You will have a negative deflection. This is the negative deflection here, what we called as the Q wave. And it represents the septal depolarization. This is the septum. First of all, the septum depolarizes, then the ventricular muscle, the apices would depolarize. So the Q would be formed because the current is flowing from the positive towards the negative in this direction. So it is there would be a negative deflection. This is your Q wave, which donates the septal depolarization. Now coming back, when the whole of the septum has been depolarized, what happens next? When the whole of the septum depolarizes, now comes the turn for the apices, these apices to depolarize. So when these apices are depolarizing, then there is, of course, the flow of charge over it like this. The direction of the vectors would add up, and a strong vector would be formed, a very strong vector, both from the right ventricular apices and the left ventricular apices. Since the left ventricular muscle have a greater mass, and it has much more electrical, because of the muscle mass, there are more electrical current generation, so it would be very strong. So the direction would be towards the left side and towards the positive electrode over here. So you can see at this time there is a very sharp increase, upward deflection. This is called as the R wave, and this donates the depolarization of the ventricular apices, the apex of the ventricle. This is your R wave. So after this, the apices, when the apices are depolarized, sorry, I don't have a diagram over here which I would have shown separately, the apices and the bases. So just consider it in this diagram. Once the apices are depolarized, the last things to depolarize are the bases here, the bases of the ventricles, this area. So now what happens? How would the current be flowing? It would be then again flowing in this direction, upwards, to depolarize the bases. So the flow of the current is away from the positive towards the negative. So what would happen? You would have a negative deflection. And this negative deflection, this wave is called as the S wave. And this is denotes the depolarization of the bases of the ventricle. It means that now the bases of the ventricles are depolarized and the whole ventricles are depolarized. Now, when the whole of the ventricle is depolarized, then of course you have an isoelectric line that follows after an S wave, denoting that there is no flow of current in the ventricle at this time. So this is also called as ST segment, which is important in certain myocardial infarctions you would see later on. Now we are just left with another, after of course depolarization, you always know that there is repolarization. So in here, you can now see that the repolarization starts. Now the repolarization starts from here and would move upwards. From the apices towards the bases, it would move upward. And if you remember the rule for repolarization, for example, this is your positive end and this is your negative end. So if the charges, they move away from the positive towards the negative, you will have an upward deflection. This is your T wave, which denotes the repolarization of the ventricles. The rule for the depolarizations, there's the single rule for repolarization, which is different than the depolarization. In repolarization, because these charges are negative charges, depolarization means that there are cations spreading across all of the membrane, and in repolarization you have the negative charges which are being filled. So if these negative charges, they are going to be filled up everywhere, and they would be going towards a negative electrode, so you will see a positive deflection, which is called as the T wave on an ECG. So now I hope I have made the things clear to you. P wave shows atrial depolarization, then you have followed by PR interval, which shows you the time when the atria have been depolarized and the impulse have gone through the internodal path, through the AV node, ready for the ventricle to be depolarized. Then you have Q wave, which shows the septal depolarization, the R wave, which shows the ventricular apices depolarization, the S wave, which shows depolarization of the bases of the ventricle. Then you have an isoelectric line, which is called as ST segment. And then you have the T wave, which shows you the repolarization phase. So here now you can see different intervals and a normal ECG. Again, a review showing atrial depolarization. Here, atrial depolarization and the QRS complex shows the ventricular depolarization and then the ventricular repolarization. Now these time intervals are very important when we're doing the pathologies, the arrhythmias, the heart blocks. Then it will become clear to you, because if these time increase or decrease, so then you won't be having a normal ECG pattern. The PR interval is very important. You must memorize it about 0.16 second, and QT interval is about 0.35 second. So these are the key concept. The P wave immediately precedes atrial contraction. The QRS complex immediately precedes the ventricular contraction, and the ventricles remain contracted until a few milliseconds after the end of the T repolarization wave. The atria remain contracted until the atria repolarized, but an atrial repolarization wave usually generated but cannot be seen on ECG because it is usually obscured or buried deep within your QRS complex. So the PQ, sometimes usually you call it PR interval on the ECG, has a normal value of 0.16 second, and it is duration of the time between the beginning of the P to the beginning of the Q wave, as you saw, and this represents the time between beginning of the atrial contraction and the beginning of ventricular contraction. The QT interval has a normal value of 0.35 seconds and is the duration of time from the beginning of the Q wave to the end of the T wave, and this approximates the time of ventricular contraction. The heart rate can be determined with reciprocal of time interval between each heartbeat. For example, what does that mean? This is a normal calibrations, the standard calibration of an ECG strip. Please, I would recommend you to go through your practical copies. There's properly spaced methods of how you can calculate the heart rate, what is the speed of an ECG machine. The paper passes through it, different types of ECG machines and their relevance. So just for short, you can see here, this is an ECG strip. You can see different now. You can recognize these, the P wave, the QRS complex, and then the T wave. The PR interval, which starts from the beginning of the P to the beginning of the Q or the QRS complex, and then the QT interval, which starts from the beginning of the QRS complex to the end of the T wave, which is called as QT interval. Now you can see there are blocks. You can see this is the horizontal axis and the vertical axis. On the horizontal calibrations, you have time. You can see it is given here. So one big square is usually having 5 small squares. So this one big square in time, it is usually approximate about 0.2 seconds, and one small square within this one big square is about 0.04 second. It measures about 0.04 seconds. This is the time calibration, which is on the horizontal axis. So on the vertical axis, you have the voltages, because sometimes you are measuring the voltages of different waves, the P wave, the QRS, and the T waves. You must know the normal voltages, but sometimes we do measure them. So if we do measure them, you must remember that this one whole block, the big block, it measures about 1 millivolt, and one small calibration in it is about 0.1 millivolt. So you can add up 0.1, 0.1, 0.1 to know about the voltages of different, to calculate voltages of different waves. And similarly, you can calculate the time period. Now, in your practicals, usually, or in your OSPEs, usually you'll be given the such ECG strip, and you will be asked to calculate the heart rate. Now, different methods are given in your practical copy. You just go through them. These are the two R waves. This is an R wave, and this is an R wave. So between the two consecutive R waves, you have two methods. If the R waves fall on the same big blocks, then it's easy for you. You just count the big blocks like 1, 2, 3, 4, 5, and then just you divide it by 300. 300 divided by big blocks. But if they are not regularly spaced, then what you do, that you count the time calibration of the small square, like 0.04 second. You just calculate these small squares from R to R, and then you divide it by 1500. So these are just a single method which I told you. There are a lot of methods by which you can calculate the heart rate. We are mentioned in your practical copy. Now, why 300? Because we said that one big square over here is 0.2 second. So 5 large squares, the 5 large squares equal to 1 second. And then 300 large squares is equal to 1 minute. So if you want to know the heartbeat, usually we calculate it per minute. So if the R are regularly spaced, so you just 300 divided by number of the big squares. For example, in this 1, 2, 3. But here you can see the R waves is falling in between two big squares, so it is not properly placed. If the R would have been here, this one R would have been here, and this one would have been here, then it would have been easy for us. Now 300 divided by number of between two R consecutive big squares, or 1500, since 1500 equals to 1 minute on an ECG strip. So you can if the R are not regularly spaced, or due to arrhythmia you have different rhythm. So what you do that you just count the small squares in this. For example, over here, I guess it's 23 small, 0 0.04, 0 0.04. Just count the 0 0.04 squares. It is around 23. So you just divide 1500 divided by 23, and you will get the heartbeat around 65 or 67 beats per minute. Now, depolarization and repolarization wave, this is the same depiction showing an electrode which is connected to a reader which detects the current. So whenever there is flow of the current, you know from the positive, the cations usually are moving, so you will have a positive deflection. We have done that rules, and if you will have a positive wave after the end of the depolarization, and then what happens, the repolarization starts, and the repolarization is at the end of repolarization will get a negative deflection. And whenever there is completely depolarization or completely repolarization, then you won't get any wave, you just would have an isoelectric line. So this is a calculation of the heart rate, that is if we have RR interval, if it is regular, so 300 divided by number of large R squares between two consecutive Rs, 300, because 300 large squares is equal to 1 minute, 5 large squares is equal to 1 second, 1500 small squares is equal to 1 minute. So you can do that, and if RR is not regular, so you can do by this method. Mean vector, we just already discussed what is meant by mean vector. For example, different current or charges, they would add up to make one. For example, these are the positive charges over here, and then positive charges over here, and then positive over here. So they all would add up and form a final big vector, which usually has an axis towards the left. That is because the left ventricle has a greater muscle mass and greater electrical activity. So ventricular depolarization starts at the ventricular septum. We did this in the diagram, you all know now. It starts at the septum and the endocardial surfaces of the heart. The average current flow positively from the base of the heart to the apex. At the very end of depolarization, the current reverses from about 100 second and flows towards the outer walls of the ventricles near the base, where it is the formation of the S wave on an ECG. Now we did different types of leads, that is unipolar and bipolar. So let's review it here. Let's do the chest leads over here. Let's do the augmented limb leads, because we didn't do that in detail. We did the bipolar limb leads, the recording from the leads. And if you memorize, sorry, this is lead 1 and this is your lead 2 and this is your lead 3. And you know that what areas of the heart you are looking at. By lead 1, you are looking at the left side of the heart. By lead 2, called the long lead, also called as a rhythm lead, because it spans, you can see it covers the heart from a greater view, and you are looking from inferiorly from below up, because the positive is down, and then you have the lead 3, which is also covers the inferior aspect of the heart. So this is just a review. You go through these leads, go through your practical copy. How would you position a patient for an ECG? The Ethiopian law. The Ethiopian law states that the electrical potential of any limb equals the sum of other two. The positive and the negative signs of the lead must be observed. For example, I told you that lead 1 plus lead 3 is equal to lead 2. So now coming to the augmented limb leads and the chest leads. So first, the augmented limb leads are unipolar. That is, they have only one exploring electrode. This is the electrode is positively. If this positive electrode, all of these are the positive electrode. If the positive electrode is placed at, this is your right arm. If it is placed at the right arm, you call this at augmented limb lead R, right arm. So in the short form, you write it AVR. It means augmented limb lead right arm. And AVL, if the positive electrode is placed on the left arm, so then the lead is called AVL, augmented limb lead, left arm. And if the positive electrode is placed on the left foot, so it would be augmented limb lead foot, left foot. So these are the unipolar. Unipolar means the exploring electrode is the positive electrode, and the positive electrode we just apply it on the right, left, and the left foot, and we see the different aspects of the heart. So now by common sense, the right side, the positive is on the right side. So what would AVR tell you? The right aspect of the heart. Now what would AVL tell you? The left aspect of the heart. And what would AVF tell you? The left plus the inferior, because it is looking from here towards your heart. So it would cover that aspect. So these are the augmented limb leads, in which only one exploring electrode, which is always positive, is applied, and different positions of the heart are usually seen. Now coming to the chest leads, you have 6 chest leads, that is AVL. We have 6 chest leads, which is from V1 to V6 here. Now the proper positioning, the areas, how to palpate for the patient, you can see different videos as well, and practically you can also perform, just make someone in a supine position and just try to palpate the areas at least. For example, the V1, coming to the V1, it is usually spaced, this is your angle of Louis. So from the angle of Louis midline, if you go and palpate, for example, the first intercostal space, the second, the third, and the fourth. So usually in the fourth intercostal space, your V1 lead is usually placed in the fourth intercostal space on the right side. This is your right side, on the right side. And V2 is usually placed in the same fourth intercostal space on the left side. This is your left side. So if you first palpate the fourth intercostal space on the right, put V1, on the left put V2. Leave V3 for now. Lead V4 coming within the mid-clavicular line in the fifth intercostal space, you would put V4. Now between V2 and V4 place this precordial lead, the chest lead V3. Now the V5, you would come into the anterior axillary line. The anterior axillary line, you would put V5, and then V6 into, that would be the mid axillary line, where you would be putting your V6 chest lead. So this is the placement of different precordial leads, or which is called as the chest leads. Now these also give you information. For example, I told you that the chest leads look at your heart in a horizontal fashion, in a horizontal way, like this, in a horizontal, while the limb leads and augmented leads, AVR, AVL, and AVF, they mostly see the coronal aspect, the frontal plane of your heart. So now V1 and V2, they are looking at your septum of the heart. V3 and V4, the anterior part of the ventricle. V3, V4, the anterior part of the ventricle, and then these are the most lateral, so the lateral aspects of the ventricle. Left side of the ventricle would be, say, if we are suspecting certain changes in the left side, the lateral side, so we'll be looking at V5, V6. If we want to see some changes in the septum or the posterior MI, for example, we would see V1, V2. And if we want to see certain changes in the anterior part of the heart, we would see V3, V4. Just look at their positioning, and it's easy for you to make up what part of the heart you are looking at. So now our 12th lead ECG is complete. We had 3 limb leads, bipolar, lead 1, 2, 3. Then we have unipolar augmented limb leads, AVR, AVL, AVF, and then we have 6 chest leads, or the precordial leads. Now here are the ECG, the relative positioning of the heart. Just look, V1 and V2 looking at your septum, V3, V4 looking at most anterior parts, superficial parts, and V5 and V6 more left lateral parts of your heart. Now coming to the ECG, depictions from different leads. For example, this is lead 1. I don't know what happened to this diagram because I can't see the different leads. That is 1, 2 and 3 I can't see, but okay, whatever we can see now, V1 and V2 usually you see on an ECG they would show negative deflection. You can see these waves are going down, it would show negative deflection. V3 is equivocal, some positive, some negative sometimes. V4, V5, V6 usually you have positive deflections in them. V4, V5 and V6 you have positive deflection. In lead AVR you have negative deflection. However, in AVF, AVL and AVF you have positive deflection. In all of the limb leads 1, 2 and 3 you have positive deflection. I can't see the 3 over here, but you have positive deflections on an ECG. You must know the normal deflection, like on lead 1 you must see a positive deflection. If you see negative deflection, that is something abnormal, that is something disease form of the heart. So you must know the normal deflections. How would you be able to seeing these on an ECG? Now bipolar limb leads, these are the relative voltages. For example, in one you have 0.5, in two you have, this is the greatest voltage. In lead 2, I told you the lead 2, whenever we get an ECG, if I want to see heart rate, I would see lead 2. If I want to see something wrong with arrhythmias or something, I would see lead 2 because it would give me great detail. It has a greater voltage, 1.2 millivolts, and then lead 3, which is 0.7 millivolts. Now these are again the other precordial leads, and now you can see the negative deflection, V3 equivocal, positive plus negative, and from V4 to V6 you have always positive deflections. So augmented unipolar limb leads, we are done with them, AVR, AVL and AVF. You all know, so I won't be discussing from here. So that was the last slide. Now objectives. I hope you understood. You must, these are the objective: understand the different waves in normal ECG, learn the normal PR and QT intervals, very important when we're doing long QT syndrome, and we'll be doing hard blocks, and we're doing long QT syndrome. So you must know the normal timings of it, and you must know from where and where till end. Usually in your auspice you will get an ECG strip, and you will have to calculate the PR interval and the QT intervals. You must know कहाँ से वेव शुरू होती है, कहाँ खत्म होती है. Then learn the difference in depolarization and waves, and then they learn the voltage and time calibration of an electrocardiogram. Please open your practical copies for this, go through it. Note they have given you different ECGs, there are different time calibrations on it, so you can do it easily, nothing difficult in it. Learn the measurement of electrodes in the bipolar limb leads, chest leads and unipolar leads. You would be given an exam auspice, you are usually given leads. For example, they are different colored, and then you know this is a positive and negative, and you are asked question on which hand you have to put. If this is lead 1, where are you going to put the positive, where are you going to put the negative? So you must know that. Understand the Ethiopian's law. For understanding the Ethiopian law, you must know your Ethiopian triangle, you must know the voltages and leads behind it, and you must know you are usually given in your MCQs, you will be given voltages like in two leads, and you will be asked to calculate the third one. So you must